We'll go ahead and move on to physical function. Sarah, are you on?
I am. Can you see me okay?
Yeah, I'm going to go ahead and stop sharing my screen so you can share yours.
Awesome. Will do. All right. Hello, everybody. My name is Sarah. I'm a physical therapist at UCSF, and I'm going to be taking us through our physical function exam that's going to be done by the PTs at each site. And this is essentially the lumbar spine exam as well. All right. So we'll play here. And just so everybody kind of knows the format. So we're going to go through and we recorded these training videos in sequence, and then we've been making edits to our protocol as recently as this week. So the videos are clipped. So bear with me. I did the best I could in that regard. Okay, so for a physical function exam, so this will be in the operations manual, but generally equipment you're going to need: exam table, preferably a high-low, especially important if you have really tall or really short PTs, a chair that's sturdy without wheels, inclinometers. One is enough. You could also use two for the spine measurements. Goniometer, you're going to at least need a large one. You can also use a small one if preferred, as long as you can get accurate measurements. You're going to want pillows for participant comfort. One is usually okay. Some people need two under their head. A stopwatch, 2 cones, tape to mark the floor, a measuring tape, a reflex hammer. And then for participant clothing, you're going to want to make sure that they can expose the skin on their legs from the knee down, and then expose their low back. And some of the tests are going to need to be barefoot to make sure they're comfortable taking off socks and shoes. General tips for this: your physical therapist needs to be blinded to the participant diagnoses and imaging results. And when we went through this, I was recording the values on our case report form just to kind of practice that, and it was not very efficient. So if you have an assistant who can write down results while your PT is taking the measurements, that would be best. Obviously, use your judgment for this if you feel like any of the exam results are going to be changed by what you say verbally. And then make sure before you start your physical exam that you're aware of baseline pain rating and your location of symptoms so that you can assess for changes when that's appropriate.
Sarah, this is Trisha. So
yes.
At UCSF, what we're going to do is have our study coordinator with you when you're doing your exam, so you can call out to him the values and he can fill in the case report form. Unless there's, a value that you can just come over and mark down yourself if you don't want to say it out loud. So that's something that the other sites can think about doing too, but it makes it go much more quickly to have a recorder. And if the study coordinator will have to shadow the participant throughout the day anyway. So I'm hoping that would work out at your sites also.
All right. Any questions so far before we get on to the actual exam components? Okay, feel free to interrupt me if you need to. Okay, so our exam sequence is important. We're going to go from standing to seated to supine to sideline to prone. So please stick to that for efficiency and also comfort for your patient or participant. So our standing tests, we're going to start with some functional outcome measures. So we'll go to the 4-meter walk test first, and I'm just going to play this video.
This is the 4-meter walk test. So what you'll do is have your participant do a practice run first, and then you'll do 2 timed trials. So we're going to show you the timed trials next. Okay, so you are going to walk at your normal speed. I'm going to start the timer when you get to the cone, and I'm going to stop the timer when you get to the second cone, but I just want you to keep on walking through so you don't slow down, okay? All right, whenever you're ready, go for it. Okay, and you can stop. And then I will record my first one.
And that's in seconds, by the way.
Okay, and then we can actually go the opposite direction. Whenever you're ready.
Is it this cone? Is it this mark or the
It's
cone?
the same cones.
Okay.
Yep. All right. And that's it for the 4-meter walk.
Okay, so for that one, you're just gonna put your measurements in seconds and you choose the best of the two. So the 2-minute endurance walk test, we're not gonna watch the entire 2 minutes, but watch the beginning and then I'll kind of skip to the end to show you how we did the measurement.
Okay, this is the 2-minute endurance walk test. So we've got 2 cones set up here on the floor. Ours are 25 feet apart because that's what we have for this space. You can do them up to 50 feet apart. What you will do is have your participant walk, starting at 1 cone, down and around the second cone, and then back. And so you're gonna keep walking around the cones for the whole 2 minutes. When it gets to 2 minutes, I'm gonna stop the timer and ask you to stop walking. So wherever you are, I want you to stop. And then tester, your job is to monitor the clock and also to monitor the distance. So you're gonna have to keep in mind, okay, 1 lap, that was 25 feet, 2 laps, another 25 feet. And then wherever they are, at the end, measure that as the portion of that distance, and then that is your value for the 2-meter walk test. 2-minute endurance walk test, excuse me. Okay. All right, are you ready?
Ready.
All right. On your mark, get set, go.
So we're gonna skip forward here. So she keeps walking around the cones. And then, let's see.
And stop. Okay. So she did about 15 laps. And then I'm gonna get my tape measure and measure from the cone to where she is.
So basically, your end result is going to be in inches. So you're going to convert however many laps and feet that was to inches, and then add the remaining inches for however far they get past that last cone. And then that will be your value for the 2-minute endurance walk test.
Okay.
All right, any questions about the walk test so far? Oh, and Trisha or Lucy, if you wouldn't mind watching the chat for me, that would be great in case anyone puts a question there.
Will do.
Thank you. Okay, standing balance test is next.
So this is the standing balance test. So what you're gonna do first is make sure you have your stopwatch and a surface that is high enough for your participant to hold on to at the beginning of the test. And then you're gonna demonstrate the 3 standing balance positions. So I'm gonna show you 3 different positions that you're gonna put your feet into. And you're gonna be allowed to hold on to the table while you get into position, and then I'll ask you to let go, and that's when we'll start the timer for 10 seconds. Okay? So the first position is you're gonna put your feet together, heels and toes, so you can hold on to here if you need to. Okay? And then go ahead and let go, and we'll start the timer. Okay, so I'm timing for 10 seconds. Very nice. Okay, and go ahead and relax. And so obviously if your participant has any balance issues, be closer, make sure they don't fall. Okay, the next position is you are going to, you can choose which foot you want to use. You're going to put the toe of one foot kind of to the arch of the other. Okay, yep, and then you can go ahead and hold on. And when you're ready, let go. So this is the semi-tandem position. Great, go ahead and relax. Okay, and then this last one, I'm gonna stand a little closer to you. So what I want you to do is put one foot in front of the other, heel to toe. Yep. And then when you're ready, you can let go. And you're again doing a 10-second test for this. And relax, good job.
Okay, so this one is scored with 1 point for the feet together or the Romberg position, 1 point for the semi-tandem position, 2 points for the tandem position if they get to the 10 seconds. If they're anywhere between 3 to 9.99 seconds, then they get 1 point for the tandem position. And if they're below 3 seconds, they don't get any points. And so your max score here is 4. Everything is eyes open. And then last functional outcome measure is the 5 times sit to stand.
So this is the 5 times sit to stand test. So again, you're going to need your timer, and you're going to need a chair, preferably one that's relatively standard height, and that is stable, so it's not going to move while the participant's getting up and down. So what you are going to do is you're going to cross your hands over your chest, okay? And then I'm going to ask you to stand up fully and sit down fully 5 times, as quickly but as safely as you can. Okay, so the second your bottom leaves the chair, I'm going to start the timer, and then the second it touches the chair on the 5th one, I'm going to stop the timer. Okay, whenever you're ready. Great, so that was 13.8 seconds, and I will record that. If your participant requires use of their hands, that's okay. Just make sure you note it in the comments section.
Okay, so once we're past the functional outcome measures, we're going to get into the lumbar spine exam. So our standing tests are going to include an observation of flexion and extension for aberrant movements, then centralization and peripheralization to check for radiating or referred symptoms, and then a measurement of active range of motion and a standing single limb heel raises to begin the myotome screen.
And so what we're looking for with this is any symptoms. So you're going to be asking them how they feel, and at the same time you're going to be observing, okay? So first I'd just like you to bend forward and then come back up and let me know if you feel any pain with that. Okay?
So I'm looking for a painful arc here.
Okay.
I currently do not feel any pain.
Okay, no pain. So because she did not have any pain.
Oh, and I'm going to pause for just a moment. So we had another test before this that involved me asking Lucy some more questions, and she had mentioned that she doesn't have pain usually, but when she does get pain, it's centrally in the low back. So that was in my brain as we're going through these tests, just for your information.
That would be a negative painful arc for flexion and a negative painful arc on return. Next thing is I'm going to have you bend backwards at your low back or your waist, okay? You can have hands down here or hands on your hips, whatever's more comfortable. All right, go for it. And come back. And any pain with that?
No pain.
No pain. Okay, so negative painful arc on extension. Gower's sign or thigh climbing. I'm just going to demonstrate. She did not do it. But it would be if she got down here and then she walked her hands up her legs. That would be a positive Gower sign. Okay, so she has a negative for that. And then I'm going to watch her one more time, just looking for instability catch or reversal of the lumbopelvic rhythm. Okay?
Okay, so I'm going to define those really quick just so we're all on the same page. So an instability catch is a catch, a stutter, or a hitch during the flexion and extension motion, or basically looking for movement outside of the sagittal plane. So if it's not smooth, if they go into rotation, if they stop, if they go into side bending, and then reversal of the lumbopelvic rhythm. So normally what you should see is that as they initiate flexion, they initiate from the lumbar spine and then they flex the hips afterwards. And then when they come back up, they should be initiating that extension from the hips and then lastly extending the lumbar spine. So if you see that flipped, which actually you'll see in the video, then that would be a reversal of the lumbopelvic rhythm.
So let me come over here. Go ahead and bend forward and come back one more time for me. Okay, So I didn't see an instability catch, which would be moving into rotation or side bending or kind of hitching with movement, so not smooth movement. She did have a little bit of reversal of the lumbopelvic rhythm, meaning she bent more at her hips first, and then she kind of let her back bend. Okay? All right. So
Next, we go to centralization and peripheralization, which despite Lucy not having any radiating pain complaints, we want to do this anyway just to check. So here we go.
All right. So next, make sure you know whether or not your patient has ever had radiating pain down the legs. So have you ever had pain that radiates down the legs, or is it usually just in the back?
Just in the lower back.
Just in the lower back. Okay. So using that to inform, we're still going to do the centralization peripheralization test to see if we get the pain to move anywhere. So I'm going to have you bend forward and come back up 10 times. And I want to know if your pain changes in that time, either intensity or location. Okay, go for it.
We're going to skip a little bit just for time's sake, but she bends forward.
Yeah, how'd that feel?
Felt good.
Okay, okay.
No change in pain.
No change in pain. Okay, now I want you to do 10 again, but this time bending backwards. Okay, beautiful. How'd that feel?
No change in pain.
No change in pain. Okay, so she did not demonstrate any centralization, which would be pain coming up more proximally, or peripheralization, which would be pain leaving the back and going into the buttock, hips, or into the legs. All right.
All right, and then our active range of motion measurement.
So next, you're going to get your inclinometer and measure lumbar flexion and extension range of motion. So you want to make sure you zero your inclinometer first. Okay, so the little weight is at 0. And then I'm going to ask my participant to roll up their shirt a little bit so I can see their back. You need to locate landmarks T12 and S1. Do you mind if I curl it up a little more? Okay, I'm just going to kind of get to right up here. Okay. I'm going to use the iliac crest as my L4 and then kind of count from there. And you can verify T12 with that last rib coming off. Okay, perfect. So then you're going to set your inclinometer up at T12 and you're going to zero it again. Okay, now this time I'm going to have you bend forward as far as you can. Okay, and I'm looking at the degrees. Okay, and so she gets to about 105, and then come on back up. Beautiful. And for efficiency's sake, you can also look at this in extension. So now I'd like you to bend backwards. Okay, oops, sorry. Go back there one more time. Beautiful, and come on up. And she gets to about 50. So I'm just gonna write those numbers down. So for flexion at T12.
Okay, so I wrote down the degrees for each. So the flexion measurement under the flexion category and the extension measurement under the extension category. And then you do need a second measurement at S1, which is what we'll look at next, so that you can actually calculate how much flexion and extension there was. You do have the option, if you have the ability to coordinate it, to use 2 inclinometers at the same time if your participant has a long enough torso.
So I'm going to find my L4 again with the iliac crest and count down. You can also find the dimples, which will be in line with about S2, and then go up and find S1. Okay. Once you've located it, you again place your inclinometer on the spine and you zero it. All right, awesome. Okay, can you please bend forward for me again? As far as you can. Okay, oops, sorry, stay there for me just a second. Okay, and so she's getting to about 70 and then come on up. Okay, good. and then go ahead and bend backwards. All right, get to about 15 there. Okay, thank you. You can bring your shirt back down. And so then I'm recording my S1 for each one, and then you would subtract your S1 value from your T12 value to get your whole value for lumbar flexion and extension range of motion.
And if you ever can't remember which one to do, you can only subtract it one way, otherwise you'll get a negative number. So whichever way is going to give you the positive number. All right. Next is our
Sarah,
single limb
oh,
heel.
sorry.
Oh yeah.
Sarah, this is Trisha. I just wanted to know we
Go
will
for
be
it.
all the sites 1 inclinometer. So if you happen to have another one lying down, you can use both of them at the same time. But just letting you know, everybody will get one.
Thanks, Trisha.
Yeah.
Test is the S1, S2 myotome tests, which if your patient can do in standing is going to be single leg heel raises. So what you're going to do, I'll demo for you, is you are going to stand on one leg. You can use this for balance with one hand. And you are going to raise up onto your toe and then slowly back down. And I want to see if you can do 5 on each side. Okay? Good. And make sure to only use your hand for balance, okay? Good job. And let's switch feet. Awesome. Okay, good.
So our grading scale for this is, so 5 would be full range of motion with 4 to 5 quality repetitions. A 4 is going to be full range of motion with 2 to 3 repetitions. A 3 is full range of motion with 1 repetition. A 2 is partial range of motion. 1 is trace contraction, and 0 is they can't do it at all. And if you're on that end, for whatever reason, you're going to want to do the prone test later, which we'll go over. Okay, before we go to the seated test, does anyone have any questions about the standing tests, concerns, comments? All right. So for our seated tests, we've got reflexes, deep tendon reflexes, L4 and S1, Babinski's sign, and then the slump test.
So for the seated section, you're going to be taking the reflexes of the patellar tendon, the Achilles tendon, Babinski's reflex, the plantar reflex, and then you're also going to be doing the slump test on both sides. Okay. All right. Do your pant legs roll up? Okay. If your participants' pant legs do not, it's not the end of the world, but it's a lot better if they can. All right. And then ideally, you'll have them sitting with their feet not on the ground. And I'm going to raise her a little bit more to my level. So I'm going to palpate for patellar tendon first. Can you please straighten your leg for me? Yep, awesome. And then relax. Good. Now I'd like you to look straight ahead. Try not to watch what I'm doing, okay? All right. And then I'm just going to give a quick tap to the patellar tendon. And then I'll record that reflex, okay? So I would give that a 2+ or normal.
I just want to pause there. So I corrected myself. So despite 2+ being normal, the way we're going to grade it here is if the reflex is absent, diminished, normal, or increased, since there's a little bit of wiggle room in terms of what constitutes normal, okay?
Okay, go ahead and straighten this one for me. Very nice, and relax. All right, give this one a quick. Good, and I would also give that one a normal reflex. Okay, now for the Achilles, you're going to want to pull them in a little bit of dorsiflexion so you get it on a little bit of stretch. Okay? So I'm going to pull her into a little bit of dorsiflexion and I'm going to tap the back of your heel back here. Okay? And so you want to quickly tap the Achilles and then you're feeling for a plantar flexion response. Okay? And then you'll go to the other side. Yep. And give a quick tap. Good, and that one's a little more visible than the other side. Okay, next, I'm going to run this end of the reflex hammer on the bottom of your foot. Okay, so it shouldn't be painful, but it'll be a little tickly.
Okay.
And so what you want to do is run it along the lateral border from the heel towards the toes, and then you're going to swipe over across the metatarsal pads towards the first metatarsal head. So I'll show you on this one a little easier. So we'll come here, we'll go up, and then we'll swipe across.
So this
And
is
I'm
the
gonna do it again,
plantar
so it's a little
reflex
quicker.
looking for Babinski's
Yeah,
sign.
good. And so what you're looking for an abnormal response would be dorsiflexion of the hallux with fanning of the toes. A normal response would be curling of the toes, including the hallux, or nothing at all. Okay? So you get a negative Babinski sign on this side, and we'll do the same thing here. Good. All right, and negative there as well. Okay.
So for Babinski's, you just want to make sure you're firm enough, especially if you have a relatively dull reflex hammer on the end.
Lastly, for the CD test is the slump test, okay?
Okay.
So what I'd like you to do, come a little closer to the edge for me. All right, so I want you to really slump down, okay? Bring your chin to your chest and just let your whole body slouch.
Okay.
Okay, go for it. Yep, okay. Now, what I'm gonna do is kind of maintain here because sometimes people want to come out of it. So I'm not gonna push her down, but I'm just gonna kind of guide her to stay in this flex position. Now, what I'd like you to do here is straighten this leg for me. Yep, straighten it all the way. Okay, any symptoms with that?
No.
Okay, now can you keep your knees straight, bring your foot back towards your face? Any symptoms with that?
No.
Okay, and then let it relax and let it down. We're gonna do the same thing on the other side.
Okay.
Okay. How's that feel?
Okay.
Good, and then come on down. Okay, and relax. So, negative slump for her. If she was someone who had radiating pain and we weren't reproducing it with this, you can add other maneuvers. You can add up the leg. So go ahead and slump for me again. So you'll have to kind of ensure that they stay down here. We'll straighten here. Okay, bring this in. So you can add adduction, internal rotation of the leg to kind of wind the system up a little more. If she did say with just knee extension or with the knee extension dorsiflexion, ow, yeah, I feel that, and she's getting radiating pain in one leg or the other, I would say, okay, now lift your head up. Okay. And if that changed her symptoms, especially alleviated them, that would be a positive slump test. Okay?
So what you want to document for slump is not only positive, negative, but location of symptoms, particularly so we can tell the difference if they had a positive slump on the same side or a positive crossed slump. Okay, quick pause for questions before we go to the supine section. All right, okay, so supine tests, we've got quite a few. We're gonna do the trunk flexor endurance test, check dermatomes with light touch, myotomes in supine, and then check some flexibility and core stabilization with the popliteal angle measurement, the Thomas test, and the active straight leg raise.
So this is the supine sequence. So we're gonna start with the trunk flexor endurance test, which we're gonna cap at 30 seconds for time's sake. So go ahead and bend both of your knees and keep them flat, feet flat on the table. Okay, then what you're gonna do, don't do it yet, but when we start the timer, you're gonna lift up at your shoulders here and you're gonna try and get your shoulder blades completely off the table. Okay, and then we're gonna see how long you can hold it. So what I'm looking for is can she clear the inferior border of the scapula from the table? All right, so when you are ready, go for it. Okay, so she's there, I'm starting the timer.
Okay, I'm just gonna pause. You don't have to watch the whole 30 seconds, but she makes it. So you want them in hook lying, knees about 90 degrees of flexion, feet flat. Do not stabilize them. They need to stabilize themselves. And then they should flex the trunk, arms at the sides, clear that inferior angle of the scapula. And so you can palpate for that and just monitor start the timer as soon as they get there. And if they touch that inferior angle down, then you stop your timer. Okay. They can also opt out, obviously, if they're having pain or if they decide that they want to be done with the test.
All right, next while we're here, we are going to do dermatome light touch testing for L3, L4, L5, and S1. So you're going to need access to the medial femoral condyle, medial malleolus, the dorsum of the foot, and the lateral border of the foot. Okay, so what you want to do first is verify sensation. So I'm going to have you close your eyes. I'm going to touch you in random places on your legs. I want you to say yes if you feel it. Okay. And so it's best practice if you try and randomize these, but get them all done.
Yes. 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 Yes.
Okay, great. Then you're going to verify, especially if sensation's intact, that they have the same sensation on both sides, that there's not a quality difference, okay? So now I'm going to touch left and right at the same time. I want you to just say if they feel the same or if they feel different. Okay? Here.
Same. 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 Same.
Good. If they say different, you want to ask them to qualify that. So, okay, what feels different? Does that side feel more? Does that side feel less? And usually try to do it in terms of the affected side. So if the affected side feels more sensitive or less sensitive than the other side.
So you'll document that as normal, increased, diminished. And then with this one too, make sure that if you're doing like little swish motions that you touch a small surface area, you do not want to do a big sweep because that is a different type of receptor that you're going to get besides the light touch receptors.
Okay, all right, so come here. So I'm going to stabilize here and then I'm going to give you a push. Ready? Keep it there, don't let me move you.
So L2 for hip flexion, you can test this on opposite side or same
Good.
side.
And then bring that down. And then we'll slide to the other side. So what we are doing for the grading for these is 0 to 5 with no pluses and minuses. So you want to review that grading scale. Lift this leg up to vertical. Oh, sorry, we just did that one. This one, just kidding. Coming up. Okay, good. So I'm going to stabilize. Don't let me push you down. Ready? Go. Good. Okay. And then you're checking in. Any pain with that?
No.
No. Okay. So for knee extension, I'm going to keep her on this side. I'm going to lift your leg up just a little. You can prop with your knee here. Then I'm going to ask you to straighten. Okay. Good. Make sure they can straighten all the way against gravity first. And then bend a little bit. Now hold it there. Don't let me push you down. Okay. Hold, 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 hold. Good. All right. Let's do the other side.
Okay, so you want to make sure that you hold the Myotome test for at least 5 seconds, give gradual resistance. If it is not comfortable for you or body mechanics wise, it's not a good idea to get your knee up there. Just prop their thigh with a bolster or a good sized pillow so that they can start in some knee flexion and really have to extend against gravity. Okay, so L4 and L5, we're going to have dorsiflexion, tib anterior, and then great toe extension, extensor hallucis longus.
L4 for dorsiflexion. So in this position, I'd like you to pull these toes back towards your face. Yeah, good. So I'm going to stabilize here at the tibia, and then I'm going to try and dorsiflex her. Oh, and she did this kind of automatically. You really want to make sure tib anterior is going. So they'll come into dorsiflexion, a little bit of inversion, okay? So hold right there. Don't let me move you, okay? Strong as you can. Go, 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 go. Good. Okay, hold for at least 5 seconds. Let's do this side. And that goes for all these Myotome tests. You want a 5-second hold. All right, hold that. Hold, 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 hold. Very nice, relax. You doing okay?
Yep.
Okay, next we're gonna look at L5, which is great toe extension. So I'm gonna say, can you lift this little toe up or big toe up like that? Yeah, good. So you wanna stabilize at the metatarsals, lift that toe. Yeah, good. Hold it there. You want to use one finger at the nail bed. Don't let me push you down. Hold it, hold it, hold it, hold it, hold it. Beautiful. Let's do this side. Okay, so lift this big toe up just like that. And hold it there. Good. And hold. Don't let me push you. Hold, 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 hold. So again, make sure you're at that distal phalanx or the nail bed, so you're testing EHL, okay, and not extensor hastis brevis.
All right, and then last for our mitome testing are the everters for S1.
Okay, so this one, we're gonna turn the foot out. Okay, can you hold your foot just like that? Okay, okay, so I like to get on the other side, and then I'm gonna pull the foot towards me. Don't let me move you. Okay, and I'm stabilizing at the lower leg. Hold it, hold it, hold it, hold it, hold it. Very nice. And let's check this side.
So you would do that on both sides and record your grades.
We are going to measure the popliteal angle, which is hamstring flexibility. So since you're already on that side, we'll measure this side first. So what we're going to do is measure the flexibility of the back of your thigh. So we're going to bring your thigh to vertical, okay, and then I'm going to get a measurement of how straight we can get your knee once we're there.
Okay.
So I might need you to help me hold your leg. If you have an assistant, this one's good to have an assistant for. So we'll bring your leg up to here. So I'm looking for about 90-degree angles between the hip and the body. Okay, keep your thigh in this position, and we're going to straighten your leg as much as we can. We're getting to about there, and I'm just checking to make sure she stays vertical. And then you set up to measure the same way you did the knee extension earlier. Okay, so I'm setting up with that greater trochanter and then my lateral malleolus here and my lateral femoral condyle. Okay, and then come down. Good, so I'm measuring that she's about 33 degrees away from knee extension. So measure it typically like you would the knee instead of in the 100 or something degrees, so we keep it a little more standardized. Okay, and then
So you would again do that one on both sides. And just to clarify, you want that fulcrum at the lateral condyle of the femur, stationary arm lined up with your greater trochanter, and distal arm or moving arm lined up with your lateral malleolus of the fibula. Oh, I see a chat. Should we cue them or make sure they do not dorsiflex the ankle with the popliteal angle test? Yeah, I would do that. Thank you for bringing that up, Kathy. Yes. Oh, sorry, cat coming in the frame. Yeah, definitely, because you want to get a true hamstring measurement versus, having interference from a potential decrease in sciatic nerve mobility or gastroc flexibility affecting that knee. Good question. Thank you. All right, moving on to our active straight leg raise.
active straight leg raise. Go ahead and straighten both legs and come back to the middle. This one is to look for pain in response to a motor control issue or a stabilization issue at the trunk, okay? So what you're gonna do is keep this leg super straight, lift it and lower it, and let me know if you have any pain. Okay.
No pain, a little tightness.
A little tightness. Okay, let's try this side.
Same, no pain, but little tightness.
Okay, so I wouldn't go on with this test in her, but let's say she did feel pain when she lifted and lowered this leg. I would then lower the table so I can stabilize her at the ASIS. So I'm gonna become her trunk stabilizers. I'm gonna stabilize her here. Now I'd like you to lift that right leg again and lower it and tell me if that feels any different than when you did it on your own. Okay? You try and get out of their way. Good, and come on down.
No pain.
Okay, okay, so if she had no pain before, we wouldn't have gone to this, but if she had pain before, then we stabilize. If the pain continues, that's a negative active straight leg raise. If the pain resolves or improves when you give them that manual stabilization, that is a positive active straight leg raise.
And it would be good too if you could note in the comments where they're experiencing pain. For example, if they're experiencing their radiating pain versus this test has usually been validated for low back pain, pelvic pain, hip region pain, things like that. So make sure you note where they're experiencing symptoms if the test is positive. Okay, and then our last supine test is our Thomas test.
You are going to want to get your participant at the end of the table. So you're going to scooch all the way to the end and go ahead and sit. With your legs hanging off, yeah. Okay. And the height of the table is up to you for good body mechanics. Okay, so now, have you scoot a little more close to the edge. You want the hips really close to the edge. Now, I'm going to have you lie back and bring your knees to your chest with you. So your patients might need help with this. You might need to kind of facilitate that. Okay, so I would come here, bring those knees up at the same time. Yep, and just come to your back. Good. Okay, now I'm going to ask you to keep this leg right where it is, okay? And then I'm going to ask you to let this leg fall down this way. And so I'm observing. Okay. So she's got a positive Thomas test because we're not getting to neutral hip extension here. Okay, she's still in hip flexion. Okay, you can also have a positive if you observe lateral deviation of the thigh, which we do. So if I bring her to neutral, that's over here. That's probably hard for you guys to see, but she kind of fell out to the side. Another thing I can test for is that quad, and that can give me a positive too. So if I straighten her leg and she's able to come to neutral, that lets me know that that quad is also a little tight. So that improved her a little bit, but she's still in a decent amount of hip flexion there. So that would be a positive on this side. So then I'm going to bring her back up. I'm going to ask you to keep that one right where this one is. Okay, make sure you hug it tight. And then we're going to let this one fall down.
Okay, I'm going to pause there. So definitely check both sides. What you want to note, just positive or negative. You don't have to know what muscles you think they're tight in. Just be aware of the ways in which you can get a positive. So you can get a positive if they don't get to neutral hip extension, if they laterally deviate significantly, or if you sense quad tightness as well. If they're unable to keep their knee to their chest, add manual stabilization so that you stay as standard as you can side to side. And we do prefer this one off the end of the table, so try not to do it off the side of the table. Okay, to go into side lying, we have one test, which is just hip abduction, specifically for gluteus medius.
The hip abduction test, you're probably going to want them to be a little bit lower. We're going to test gluteus medius. Okay, so what we're going to do is another strength test. So I'm going to help you get into a position, and I'm going to ask you to hold it while I give you resistance. Okay, scoot back a little closer to me. All right, I'd like you to bend this knee a little more. Okay, and then we're going to keep this one nice and straight. Now I'm going to help you. We're going to lift this leg up and bring it slightly behind you. Okay, in order to do that, I'm going to need you to roll forward just a little bit. Yep, so you want to make sure the hips are stacked on top of each other so that they're not rolling backwards. Okay. You can have them go into the motion on their own, but most people will not do it correctly. So I like to guide the first time. Okay, so I'm bringing her into hip abduction. She's in pretty neutral rotation, and now she's in a little bit of extension too. Okay, I want you to hold right here. Okay, if they're having trouble kind of figuring out how to do this, or if they start kicking in that TFL, you can tap here. Okay, use this muscle, okay? All right, now I'm gonna let you go. And I want you to hold it there, okay? All right, so I'm gonna let her go. Okay, if she's able to hold it, then I give some resistance. Now don't let me move you. Okay, gradual resistance for at least 5 seconds. Good. And my resistance direction is in adduction and a little bit of flexion at the same time too. Okay, so kind of this diagonal downwards. All right, beautiful.
Okay, so you do that on both sides. You don't have to passively take them there first. You can have them do active motion if they've got the technique down already, but make sure that they're getting to at least that 3 out of 5, that they're going in their full range of motion against gravity before you initiate resistance. Okay, before we go to prone, we've got 4 more things to look at. Does anyone have any questions? I know this has been pretty rapid fire. Okay, so the next section, we're going to look at hip rotation in prone passively, plantar flexion manual muscle testing, which is to be done if they could not do the single leg heel raise, hip extension manual muscle testing, and then the prone instability test. So 2 of these are videos, unfortunately, did not make it from the camera into upload land. They were lost. And so I put some pictures and I'll just kind of talk you through it, but we will definitely have those videos for you for reference once we recreate them. Okay.
All right, next, we are going to look at hip rotation motion. So you want to grab your goni again, and you are going to be measuring rotation passively at the hips, okay? So I'm going to bend this knee, okay? All right, okay, you can relax. There you go. Okay, so what we're gonna do is I'm gonna move your foot inwards and outwards, kind of like a windshield wiper, and just feel your motion first. So I'm gonna stabilize here at the pelvis, check out external rotation in this direction, okay, and internal rotation in this direction. Good, okay. So what I'm looking out for too is that she doesn't abduct too much. So since we know she's got a little hip flexor tightness, okay, so I'm not gonna pull her into more knee flexion. Then I'm gonna get my goni set up. Okay, so you're using, you want your stationary arm to be straight up and down. Moving arm is gonna follow the tibia. Okay, so looking at internal rotation. Okay, we're getting, and I'm kind of pushing the goni into the table a bit so I can get my fulcrum a little closer to that patella. Okay. So, hold on. I'm gonna move your leg over just a little. Do you think we can actually have you scoot down the table a bit? I think that'll be a little easier for me. All right, that'll be good. Okay. Here, okay. And so I'm watching her pelvis. If I take her too far and her whole pelvis moves, you're going too far. Okay, so she's got a little over 20 degrees there. And we'll go into external rotation. Okay, and I'm already seeing some pelvic movement there. Good. And about 18 degrees there. So if your table isn't squishy like this one, you might need a goni that's a little smaller so that you can get that fulcrum correct.
Okay, so you would do that on both sides. And then moving on, okay, so this is one of the videos we lost, but for plantar flexor, if they can't do the standing test for whatever reason, it's painful or balance isn't good enough, you wanna do it in prone with the knee extended, foot hanging off the table. So palpate, make sure they get that at least 3 out of 5 and they're firing gastroc and soleus. And then you're going to stabilize at the lower leg. And then you're going to give resistance at the foot, not the toes, at the foot to try and push them into dorsiflexion. And then hip extension manual muscle testing.
Have you lift your leg again. And then I'm going to give resistance down here, trying to push you down.
Okay.
And similar to the other tests, I want you to keep your leg up.
Okay.
Okay, so I'm going to stabilize at the pelvis. Go ahead and lift up. Good, keep that leg straight and don't let me push you down. Hold, 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 hold. Good. And so other things you want to look out for is making sure that they don't start super flexing their leg. Okay, you want them to stay relatively straight. All right, and again, you
Okay, and so that one we're doing on the 0 to 5 scale again, just like the myotone testing and the hip abduction strength test. And again, we're doing the 0 to 5 without those pluses and minuses, just so that there's less variability, and hopefully it'll be a little bit more reliable in terms of inter-rater reliability. Okay, and then this is the other one we lost the video for. So the prone instability test, this picture is from Josh Cleveland's book for ortho assessment, but basically they're going to be at the edge of the table, that you have them hug the table. You're going to give them a posterior to anterior pressure, and you're going to work your way all the way from L5S1 up to L1. And so you're going to give pressures. If at any point you produce pain, you're going to have them lift their legs up, which is going to engage the paraspinals. And then you're going to give that PA pressure again. And if that reduces the symptoms when they have their legs lifted, that is a positive prone instability test. If there's no change in the symptoms, or if they didn't have symptoms with any of the PAs to start with, then that's going to be a negative prone instability test. And so again, we'll have pictures in the op manual, and then we will also upload a video for you all. Okay, and then once you're done, you're just going to quickly fill out classifications for your participants. So the Quebec Task Force classification assigns them based on pain location and neurological involvement. So if they only have back pain, they're in category 1. If it's pain with proximal extremity radiation or referral, so above the knee, it's category 2. If you have pain below the knee, then it's going to be category 3. And then if they have radiation of pain anywhere in the limb, plus a neurological finding from the exam you just did, so reflex changes, sensation changes, motor changes that are consistent with a neurological problem, then you're going to want to put them in category 4. Dominant pain location, and this might be able to be filled out by the intake questionnaire too. It might already be there, but you'll want to know if they have back or buttock pain dominant, or if they're leg pain dominant, or if they have pain somewhere else dominantly, and make sure you note that, because that's probably not going to be super common, since all of these patients should at least have low back pain. And then lastly, you're going to do your mechanical classification, so based on dysfunction. So if flexion causes their pain, you're going to put them in the flexion dysfunction category. If extension causes the pain, they're going to be in the extension dysfunction category. If they have pain with both, they're going to be in the combined category. If it's non-mechanical, meaning that it doesn't follow a movement pattern, you can't reproduce it with movement, then they go into the non-mechanical section. And if for some reason they don't fit into any of the categories, then you'll put them in no category, none of the above, and you will write comments as to why you decided that. So we have all the info. Okay, that was really fast. But that is your physical function exam for the PTs. Any questions, anything else you feel you need to know? Oh, I see question. What muscle are we intending to test with hip extensor MMT? Yeah, so we're just getting the hip extensors grossly. So you're gonna have glutes and hamstrings going. We chose not to do the bent leg test because that would probably take people out who have hip flexor quad tightness. So just hip extensors generally. And then is this all being done in one session? Yes, it is. I'm worried that this much testing in one session may alter the results if the testing aggravates them as the session goes on. Yeah, and we thought about that a lot, and it was initially a lot longer. So I've run through this with Lucy. We're gonna have another mock run, and we'll see how it goes, but we'll make sure if there's a trend that we will address that. Harmonized across backpack. Yeah, so we have talked to the other sites. We don't have, complete harmony. We have little differences site to site, but we do have a ton of overlap that we've done on purpose between the sites. And that's part of the reason why we have a lot of the tests we have and took out some other common lumbar spine exam tests. Yeah, good questions.
Thanks, Sarah.
Thank you.
Yeah, thank you.